children. In this chapter, we're going to identify some of the physiologic events that are associated with a perception of pain, talk a little bit about some factors that influence the pain response. We're going to identify some considerations on effects on the different age groups. We're going to talk a little bit about some principles of pain. We're going to understand pain, different pain scales for the different age groups. And then we're going to talk a little bit about setting up a plan to care for children having pain. So your classifications of pain, when you think about pain, the International Association for the Study of Pain says that it's an unpleasant sensory and emotional experience that's associated with actual or potential tissue damage or describes in the term of damage. So it's whatever the patient says it is, right? That's what you learn. Existing whenever the patient says it does. So they're the only one can identify it and know what it's like. Now, when we talk about kids, the smaller they are, the harder it's going to be for them to identify pain. So we have to think about looking for other signs and symptoms that we see. So using our assessment skills to see if they're in pain. An infant can't really tell you that they're in pain. When we talk about different types of pain, so nociceptive is those early warning protective system. Inflammatory is when there's some healing going on, but it's causing pain. And then dysfunctional is when you can't, it happens with the nervous system and you just can't function at all. So different types of pain. So what factors influence? So we talk about pain. We're going to talk about how pain is identified by people. Age. So age has a lot to do with pain. So children, they can experience some events that cause pain. And then it says that research found that environmental and physiological or psychological factors can exert a greater influence on them. So when we think about age and gender, so the nervous system for pain transmission and perception are present before birth. So anybody can experience pain. There's some myths saying that preterm newborns or newborns can't experience pain, but they can. So typically over the years, pediatric patients haven't been treated properly for pain for many reasons. Gender and sex. So they said that suggested that boys and girls differ how they perceive pain, but that can be influenced by other factors too. The cognitive level, when a kid understands the cause and effect of pain, sometimes they can handle it better. They have better coping skills. Can they communicate? But if you have a developmentally delayed school-age toddler or preschooler, they obviously are not going to be able to communicate as if they didn't have that. Temperament plays a role in it. So they say that a child with a difficult temperament is going to be more likely to have more distress. I find in my experience that kids with maybe parents who are letting them do whatever they want, sometimes those kids have a harder time with the limits that involve treatment of pain. Some are more dramatic, things like that. Have they had previous pain experiences? So when we talk about kids with special needs, sometimes they can understand that, they're going to the hospital, they're going to need an IV, and that sometimes it takes a few times to get it in. So previous experiences. Family and cultural background, if you come from a family who, doesn't treat every little ache and pain with medication, then sometimes those kids can maybe have more of a tolerance to it. Sometimes certain cultures, they don't allow outward expression of pain. So we have to, again, use our senses and our assessment skills to see if they're in pain. So situational factors. So we talk a little bit about this. So do they understand the specific pain? What are we doing? What can parents do? Do they have coping mechanisms? That's one of the questions our child life specialists will have. How do they cope? How do they cope with things? What do you do to decrease pain at home? Do you sing a song? Do you play music? Is there a certain show they like to watch? Um, and then how's the family acting? Because if the family is all up in arms and screaming and yelling, the kid's going to be up in arms and screaming and yelling. So really, they take their direction from a parent. So trying to get the parents to maybe, handle things a little bit better can help the kid handle things better. Um, so overly protective behaviors of the family, sometimes that makes it worse. Sometimes the parents making the situation worse than it really is. All those things have effect on it. The other thing is, how's the nurse reacting? So, I've had nurses, scream and yell because a kid is sick. The family's going to take their direction from them, and then they'll be more upset. So sometimes we have to use that poker face. So we have to, even though inside we're thinking, oh my God, we have to use that because they're looking to us to see how we're handling situations. So infants are the hard ones. They can't tell you, hello, I'm in pain. We use the word inconsolability. So are they consolable? They should be able to be consoled by their caregiver. We look more at the facial expressions, body movements, crying. So the brows that are lowered and drawn together, the forehead's kind of crunched up, eyes are closed, cheeks are raised, nose is kind of bulging. They have a labial or nasolabial fold that will deepen. Their mouth is open. They're crying. They're squirmish. We're looking for changes in their heart rate. So increase in their heart rate. So tachycardia, tachypnea. What's their blood pressure doing? Kids normally are normotensive. So what's their blood pressure doing? Oxygen saturation in times of stress will decrease. Their vagal tone, sweating. So we're really looking at all these signs and symptoms of pain. There's a little acronym that about crying, and then crying has a beginning and an end, so you can kind of explain that to the parents. Sometimes kids have colic, which I mentioned, and that's really hard for them to deal with. When you get to the toddler, we're going to use the Flax scale. So you can use the Flax scale on the infant or the toddler. An older toddler, so your toddlers are 1 to 3, so your older toddler might be able to verbalize some pain. Obviously, the younger one won't. So we use the Flax scale. So the Flax scale is something you should know. So it's based on observations. So face, what does the face look like? Are they grimacing? Are they continue to frown? What do their legs look like? Are they kicking and screaming? Activity, are they arched, rigid, jerking, crying? So inconsolable is always a sign. And you can get a score of 10 total. And usually we medicate about 4 or 5 or up on the Flax scale. You can use the Flax scale on older kids, especially developmental delayed kids, because they may not be able to tell you what their pain is. It might not be accurate. So you can always use the Flax scale. When we get to the preschoolers in pain, we can use the Wong-Baker faces. There's a lot of faces. Different companies make them, but we use the faces. They may not tell you their pain. They may be more stoic because they may know what's going to happen if they say pain. Sometimes that guilt in that preschooler, they think that it's just expected. They think adults are aware of their pain and they're not always aware of it. How the Wong-Baker faces scale works is that you ask the child how they feel according to the faces. And then I also look at the child and I see where they are, because sometimes they might be happy and playing and they point to 10. So you have to do some assessment skills also with the Wong-Baker. Adolescents, so they're concerned with their body image and that loss of control. They can deny or refuse medications, but again, the parent has the final say in that. They can use a pain score of 0 to 10. And so you can explain that. The biggest thing with pain scales, you need to be consistent. So you need to be using the same pain scale that everyone else is using. And you need to explain the scale to the parents and the family so that they understand what we're looking at and what we're doing. Sometimes different cultures don't understand that. You always want to use your interpreter if needed to explain the pain scales. You can't just expect that everybody knows what they are. One of the pain assessments is the Quest. So you don't have to remember this. It's just kind of a way to think about it is ask the child what's going on, use that reliable pain scale, evaluate the behaviors. You always want to make sure that when you are medicating for pain that you reassess. And that's a big, big thing in healthcare. Some factors that affect it is the type of pain, again, the extent of it, how the family's reacting, and then their developmental level. To tell you that in my experience, kids don't want to be in pain. Kids don't want to be sick, so they won't fake pain. Unfortunately, we have some adults that fake pain to get narcotics. Kids don't know how to do that. So what you see is what you get with them. So I talked about the assessment tools, the FACES scale. There's some other ones. I've never really heard of the poker chip tool. I've heard of it, but I've never used them. There's a lot of different scales out there, but the ones that I'm concerned about or ones I want you to know is the FLAC and then the FACES. The neonatal scale, you would use that more in NICU. The NPAS scale, again, that's another one that they use in NICU. Like I said, there's 100 scales out there, but you just need to be consistent with the one you're using. Often your facility that you work at will dictate which pain scales you're going to be using, and often they are embedded into the electronic medical record. So it's pretty easy. You'll just go click, 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 and it'll give you a score. So pain management for children, we talked in our skills today, and we'll talk with when you guys come to skills, when everybody does, is the use of Sweeties. So this is a sucrose solution that is in the Pyxis, or sometimes it's in the Pyxis, sometimes it's just in the cupboard. It depends on your facility. And it is helps with infants. They call it baby morphine. Parents can dip the pacifier in or give them to the kid. And the infant, they really like it, and it supposedly acts like morphine for them. You always want to individualize your pain management. Talk to the parent. Have they ever had an IV before? This is what it's going to feel like. You're going to feel a pick, things like that. We try to always go non-pharmacologically before we start adding medications. Not all medications, like I said, are approved for kids, so we want to be very careful. We use Tylenol and ibuprofen a lot, and a lot of times that's enough to take care of the kid's pain. And then you want to talk to the parents about pain. So there's our favorites. We use a lot of ibuprofen and Tylenol. So non-pharmacologic, we can do relaxation, distraction, guided imagery. I always thought guided imagery was like, whatever. But we have patients that we use procedural sedation on. To put like a bone back in place or something like that. And we use ketamine. And so ketamine has a reaction to it that's called a ketamine emergence, and they'll come out a little crazy. I don't know if you've ever seen those videos on YouTube that parents take of their kids when they have their wisdom teeth out and they're acting all crazy. That's what ketamine does. One of the physicians I used to work with, he would try some guided imagery. So say the kid played baseball, he'd say, well, before he gave them the ketamine, he'd say, well, imagine that you're on the baseball field, and ask them what position they played. And he would kind of go into the whole baseball thing. And then he didn't really do research on it, but it would be a great research project if anyone ever thinks about it, is that when they woke up, they had less of that ketamine emergence. So it was just his own little research study he did. I used it once on a 16-year-old. She was hyperventilating because I was going to put an IV in, and she was afraid of needles. And, so I got all my equipment ready, and I was just talking to her and asked her what she liked to do for fun, and she said she liked to go to concerts. So we talked about some concerts, and I said, well, who do you like to go see? So she's mentioning the names. Most of them I hadn't heard of, except when she mentioned Justin Bieber. I had heard of him. And by the time we got all done, I already had her IV and blood work done and everything. And so after she took a break, and she's like, well, when are you going to do the IV? I'm like, I'm done. So really, it was a matter of guided imagery. We can go pharmacologic, so analgesics. We don't use too many PCAs in kids. Epidurals, we don't use too much of that. We do conscious sedation, but the new term for that is procedural sedation. So procedural sedation, it's conscious sedation is the same thing. They say it different ways. What it is we are giving enough medication to the patient that they won't remember the procedure, that they'll sleep through it, but then they'll wake up quickly. And it's not enough that it's going to depress their respiratory system that we need to put them on, intubate them. So like I said, we'll put an IV in them. Say they broke their bone and the orthopedic doctor is coming in to set that bone. We put all the emergency equipment in place. So we have, make sure the child has a patent airway. There's a lot of charting that goes on with procedural sedation. You stay in the room as the nurse the whole entire time, from the time you start to the time that child gets to their pre-sedation state. We're constantly monitoring their vital signs, their LOC. We're making sure that they have adequate sedation so they're not waking up. And then we have emergency equipment at the bedside. Medications we use are ketamine. Like I said, ketamine is short-acting. Ketamine has a dissociative effect, so they disassociate from their being. Their eyes may be open, but they are really, they're really asleep. We also use propofol. Propofol is white. We call it milk of amnesia. So you don't remember that you had anything done. If you are old enough to have had to have a colonoscopy, they use propofol, and you wake up and think that nothing was done, which is probably a good thing. So, so you're going to do certain kind of procedure. You're going to follow your policy of your hospital. There's a whole packet on this in the computer. You also are going to do a timeout, just like you would with any operating procedure. And then they're going to, you get an IV into the patient, you put them on oxygen, put them on the monitor, and then the physician is going to give the ketamine IV. We're not allowed in this state to give ketamine IV. It's an anesthetic agent, or propofol IV. The only time we can give propofol as nurses if a patient is on a ventilator. Otherwise, it's out of our scope of practice. The problem is some doctors don't know what our scope of practice is, so we have to remind them that we can't give anesthetic agents. They give enough to have the patient become calm, and then they'll put the bone back in place, and then everyone leaves except you, and the parents can come in, and then you just wait till that child can wake up, eat, drink, pee, things like that. So we do a lot of that because kids break a lot of things. So what's our role? So we're going to start the IV. We are going to prepare them. You can use therapeutic hugging while you're putting the IV in, but not for the procedure. We talked about the smallest gauge needle. We may use opt out of venipuncture, opt for venipuncture instead of heel sticks. Kangaroo care, so that happens in NICU. And then we can use the non-nutritive sucking, which is pacifier, sweeties, things like that. Okay.